Thank you. Thank you for the kind invitation for everybody. And we will talk today about my experience in the treatment of the stiff knee gait. I will show you how I changed my opinion and my surgical treatment during this year. As we know, the stiff knee gait is a very common pattern in a hemiplegic patient, and the problem of the stiff knee gait, it compromises foot clearance in swing, and the patient may compensate the problem with hip circumduction, pelvic elevation, and vaulting of the contralateral lower extremity, as we can see here in the video. There are different concerns, different curves of stiff knee gait. Let me show you all the curves that can concern the stiff knee gait. First of all, we can have a stiff knee gait in the patient with quadricep weakness, as we know in the polio patient, that stabilizes the knee in extension to avoid the fall of the knee. A second problem may be, conversely, the excessive quadricep activity, the abnormal braking activity of the thigh muscle. Another concern may be the equinus foot deformity. As we know, the equinus foot deformity pulls the knee in extension, the recurvator knee. Or another option may be the weakness of the hip flexor, the insufficient hip pull-off. If the patient is not able to flex the hip, is not able to flex the knee too. Then another option is the deformity of the foot with the equinus foot that causes reduction of ankle power. The reduction in ankle power can cause an absent push-off at the ankle, which is the main mechanism for knee flexion generation. Another option may be the premature hamstring activity during the late stage. If the hamstring are too tight, the patient is not able to flex the hip, or there is an excessive rectus femoris muscle action during the initial swing. The rectus femoris spasticity has been described as the main cause of stiff knee gait in the past, and the first surgical procedure were directed toward the reduction of the rectus femoris activity. So the first described procedure was the proximal release of the rectus femoris muscle. You can see here an incision in the thigh, the proximal part of the thigh. We can see the muscle, the sartorius and tensorial fascia lata. On the deep we have the rectus femoris, and we can make the lengthening, myofascial lengthening of the rectus femoris. There is a famous paper of Sutherland that shows that this technique improves gait in patients with enough rectus muscle spasticity. And with this technique we have any benefit for improving hip or pelvic biomechanic. This is a patient before and after surgery. We can see in the video very little improvement in knee flexion during the swing gait. So for this reason I abandoned this technique, because the surgery on the proximal part of the thigh should not directly influence the knee kinematic. The second option was described by Perry is a distal rectus femoris muscle transfer. With this technique, the rectus femoris preserves its action as a hip flexor, eliminates the knee extension effect of the spastic rectus femoris during swing, and relocates the direction of the muscle force behind the knee, converting the rectus from a knee extensor to a knee flexor. You see the picture here. We detach the rectus femoris from the vastus, and we put the rectus femoris on the sartorius or gracilis or tensorial fascia lata. There are many papers that show the activity of this surgery. For many years I use this technique too. But in the year, some authors show that the rectus transfer work only because you take out the rectus femoris from the quadriceps, because the connective tissue may constrain the muscle and restrict the motion of this muscle. We have some papers that show that the effect of rectus transfer, and it shows that the knee flexion may improve because it decreases the ability of the rectus femoris to extend the knee. And in addition, the rectus transfer may conserve its action as the hip flexor. That's why in the here I change my technique and I just make the rectus femoris muscle intramuscular lengthening and don't the transfer. So I detach the rectus femoris, it just makes an aponeurotic lengthening of the rectus femoris itself. Or another option is to make the completely release of the distal rectus femoris. As we can see here in the video, I detach the rectus femoris, I recognize it from the other component of the vastus, and as we can see here, I detach completely the muscle and take off all the is constrained on the other muscle. There are different papers that show that distal rectofemoral resection shows the same activity as rectofemoral tendon transfer. So always was my choose technique. As I told you before, taking off the rectus femoris from the quadriceps diminishes the knee extensor function of the rectus femoris, and technically it was less demanding. The incision was smaller. The patient after surgery has no pain. He can start to walk the day before surgery, the day after surgery, without pain and without any kind of immobilization or cast. This is a patient before surgery with a knee extension and after the rectus femoral release. What we can see here is just a little improvement in flexion, just not many degree of flexion. And this was shown in the literature too. The average improvement in knee flexion was just 10 degrees, and there was 20% of patients that have any benefit from this technical surgical. And we have the deterioration of the post-operative improvement. As we can see here in the video, the patient before surgery and 1 year after surgery, we say the same position of the knee and the same lack of knee flexion in the swing phase. Why does the rectus femoris does improve? There was a still activity of the rectus femoris itself. The first change in technical procedure was due to Marianne Keenan. It showed that we don't have only to take out the rectus femoris, but we have to make something of the vascular intermediate too. And they show the combination of distal rectus muscle transfer with fractional lengthening of the vascular muscle. Another very important thing that is show that the amount of knee flexion during swing is directly related to walking speed. Another very important question is if we want to improve the patient must walk at the must walk speed, because if you don't walk speed, you can flex the hip, you can push off the ankle, and you don't have the flexion of the feet. That's why we introduce another option, so rectal muscle transfer and lengthening of the vastus intermedius. But in patients, sometimes we observe patients with quadriceps spasticity that have a sense of normal quadriceps activity during walking. So there is a difference between the clinical examination in which we can see the spasticity and what happened during walking. Another paper showed that there are different mechanisms for those knee flexion in swing. Some patients don't have excessive knee extension moment during swing, and again it was pointed that we have insufficient knee flexion velocity at 12. The patient don't walk speedy. So this is a paper by the Italian group, 2012, and it was shown that the rectofemoral activity was not responsible for stiff knee gait in the majority of subjects, and the cause of stiff knee gait was the lack of push-off, was the primary cause of stiff knee gait. That's why we put another option, that was the flexor digitorum longum transfer, to improve the plantar flexion force of the ankle, as was described yesterday by Mary-Ann Keenan. In this surgery option, we take out the flexor digitorum longus, we put the flexor digitorum longus into the os calcis and calcaneus to improve the plantar flexion of the ankle. And you can see here the patient before, 3 months and 1 year after surgery. Now we can see what happened. The patient walk fast, and she can flex the knee in the swing. We have choose this option. We have make a new operation to some patient, as the patient that I showed you before was the patient before surgery, the patient after rector femur release on the right, and on the back you can see the patient after the transfer of FHL from os calcis. You can see the different, and if we see in the same patient the MG activity, we can see that before rector femoris with patient walking in low velocity, we don't have activity of the rector femoris. After surgery, the rectus activity of the rectus femoris improve because it walks faster, and after the transfer of the flexor extensor malleus to os calcis, the activity of the rectus femoris was lower, and we can see the kinematic before and after surgery. Another problem is the co-contraction, is the activity of the hamstring. As we have seen in the literature, if you perform the rectus femoral transfer without making anything to the hamstring, you can have the improvement of flexion of the knee, but you can still have the flexion posture in stance. So another option is about what to do to flexion through the hamstring. What I'm doing is usually a percutaneous lengthening of the hamstring. As we can see here, the patient before and after the treatment. I use a 15 gauge, and I just make the percutaneous tenotomy of gracilis, semitendinous, and if you need, the biceps femur too. The fractional lengthening, hollow knee extension in stance, so you don't have the posture inflection in stance, and augmentation and knee flexion in swing for foot clearance. Again, another patient. In this patient, you can see another problem. The patient is not able to walk on the parietic side, on the left side. He stays on the external rotation of the hip. He has a lack of extension of the knee. We try to make the dynamic MG on the patient, and what we see during walking, no pathologic activation on surface MG in rectus femoris, vastus medialis, and vastus lateralis. As we can see here, no activation during gait. But if in the same patient we make the fine wire MG to the vastus intermedius, you see the pathological activation of vastus intermedius. So that's why this is a publication in press, our publication of our group from Rimini, And we analyze the vastus intermedius activity acquired by fine wire during gait in the patient. We study 47 patients with hemiparetic, and what we see during the gait that the activation pattern of the vastus intermedius muscle recorded by fine wire was completely different from the normal patient. We have in the 46% of the patient a premature activation of the vastus intermedius, or in 24% of the patient we have a prolonged activation of the vastus intermedius. In the surface gain, in the subphase of gait cycle, we show the activity of the rectus femoris overall in mid-stance and in terminal send and in press swing, not in the initial stance as we can see in the normal patient. This is a MG of the vastus intermedius. We can see the activity in the press swing of vastus intermedius. In another case, the subcontinuous activity of the vastus intermedius. What we describe that we can think about the spasticity of the muscle, but we have to describe about the abnormal pattern of activity of vastus intermedius muscle during the gait. That's why what I'm doing now is just to make the lengthening of the rectus femoris and the vastus intermedius too. As we can see here, I just make a very small incision on the anterior part of the thigh, and we can see here I make the lengthening of the rectus femoris, and on the deeper part I make the lengthening of the vastus intermedius too. We can see the catch before surgery and no catch after surgery. And now we have the video of the patient before and after surgery, again with the activity of the rectus femoris and the hamstring muscle before surgery, and no activity of rectus femoris and hamstring after surgery. In this patient I perform the fractional lengthening of the rectus femoris and vastus intermedius, the percutaneous medial hamstring tenotomies, the fractional lengthening of the triceps sura, flexor to release, splat procedure to correct the varus position of the foot, and the flexor digitorum longus transfer to improve the plantar flexion of the gait, and you see the difference before and after surgery. Or in the other patient that I show you, I used to perform another option that was the release of a hip external rotator, because the patient stay in an external rotation position and he have pain of external rotation. I completely release external rotator to improve the position of the hip, to permit the patient to flex the hip and to have a good position of the foot in walking and to walk faster. And you see the patient at 3 months and 1 year after the procedure. There are still some limits in the surgery. First of all, as I told you, if you don't have a push-off of the triceps, you don't have improvement in the knee flexion during the swing phase. As we can see here is a young lady in which I performed surgery on both the flexion and both the foot, but it still remain in extended position of the knee. Or if you don't have the hip flexor weakness, if you don't have the hip flexor, the patient will walk after surgery in the same position because you don't have the strength of the hip flexor. In conclusion, the stiffening gait results from problem that arise during the late stance phase and abnormal muscle function during the swing phase, so in both activity, both in stance and in swing. The rectus femoris has a potential to contribute to excessive knee flexion, but other factors may contribute to excessive knee extension, as the inadequate knee flexion moment generated by a weak gastrocnemion. Our results suggest that the vastus intermedium muscle can contribute to stiffening gait in a stroke patient, and so we have to measure the activity of the vastus intermedium with MG before surgery. In conclusion, I want to make a special thanks to Marianne Keenan. He told me everything about my job. If now I'm here on the podium and I can share my experience with you, it's thanks to Marianne. Grazie.